Welcome to this video on surgical bed utilization. We are revisiting a foundational 1999 case study from Westmead Hospital and modernizing it with today's operational strategies and tools. Surgical bed management is a constant pressure point. From elective cancellations to emergency patient wait times, hospital occupancy rates are higher than ever, and the cost of inefficient flow is significant. While the tools have evolved from manual whiteboards to predictive AI and real-time command centers, the core principles of effective bed management established in 1999 remain unchanged. This video explores the Westmead Hospital case study. By restructuring their surgical division, they successfully eliminated bed-related cancellations, providing a roadmap for modern healthcare management. Before their reforms, Westmead faced a 30% cancellation rate. They identified key root causes, including outdated policies, poor staff education, and inefficient bed allocation, all of which contributed to empty theaters. The response was the creation of a dedicated bed management team led by a clinical nurse consultant. This team implemented a daily priority ladder to ensure beds were used for the most urgent cases. Westmead built a comprehensive system around the bed. This included pre-admission clinics, dedicated perioperative wards, and daily rounds to monitor and improve patient flow. The results were clear. Cancellations dropped to zero and were sustained. This was achieved even while reducing the total bed count, demonstrating that better flow management is more effective than simply increasing capacity. While Westmead's core principles endure, today we face new challenges. Modern tools can address issues like reactive decision-making, while the quote exit block remains an unsolved, system-wide problem. As we move into modern challenges, it's clear that demand is rising and patient acuity is climbing, leaving hospital systems with almost no buffer to absorb unexpected surges. Most systems are now operating above the 85% occupancy safety cliff. At this level, queues form and delays cascade, significantly impacting elective waiting lists and patient care. The surgical bed sits at the system's tightest junction. A bottleneck here causes a ripple effect, backing up into the operating room, the PACU, and finally, into the emergency department. The cost of a delayed surgical bed is high, impacting patient well-being, staff morale, and hospital revenue. Excess days also increase the risk of complications and infections for patients. As routine cases shift to ambulatory settings, remaining inpatients are often older and more complex. This means every surgical bed is now a high-acuity, critical resource. To address these choke points, we look at 4 levers: admission scheduling, theater and PACU flow, ward length of stay, and effective discharge planning. We will examine these further in the next section. We now transition to the frameworks that enable a systems-based approach. Before implementing specific tools, it is essential to align on mental models, including Lean, Six Sigma, relational coordination, and operations research. A critical mantra in systems thinking is to manage the journey, not just the bed. By focusing on the process, rather than the structure of the bed itself, and using continuous small-scale PDSA cycles, we can improve outcomes reliably. Lean methodologies, adapted from the Toyota production system, focus on maximizing value and eliminating waste. At Henry Ford Health, applying these principles to surgical pathology led to a 55% reduction in defective cases in just 1 year. To optimize surgical bed flow, we look at the, quote, 8 wastes. From waiting for a theater slot to unnecessary transport or unused talent, identifying these common forms of waste is the first step toward building a more efficient system. When it comes to measurement, quality and efficiency are not competing goals. They move together. By tracking key indicators like excess bed days and surgical site infection rates on a unified dashboard, teams can make proactive, data-driven decisions. Relational coordination serves as the human operating system of the hospital. Shared goals, shared knowledge, and mutual respect among the care team drive significant improvements, such as reduced lengths of stay, often exceeding the impact of purely technological fixes. Operations research provides the modeling capability to test strategies before implementation. Through discrete event simulation, hospitals can evaluate the impact of adding beds or ring-fencing resources without committing significant capital beforehand. Building on these frameworks, we now look at 4 operational levers to optimize utilization: smoothing demand, compressing length of stay, moving the right cases to the right setting, and breaking the exit block. The first lever is smoothing artificial variability. While natural variability like emergency arrivals is unpredictable, Artificial peaks caused by scheduling patterns are within our control and can be leveled out to stabilize bed occupancy. Smoothing is a proven technique. Research shows it can reduce peak bed demand by up to 19% without adding a single bed, while also creating downstream benefits like safer nurse-to-patient ratios and lower mortality rates. Our second lever is safely compressing the length of stay through ERAS, or Enhanced Recovery After Surgery. This approach optimizes the entire patient journey, from preoperative preparation to intraoperative techniques and early postoperative mobilization. Evidence shows that ERAS protocols reliably shorten hospital stays and reduce complication rates across diverse surgical specialties, all without increasing readmissions. This validates ERAS as a core engine for safe and effective bed utilization. The third lever is shifting the site of care. By moving appropriate surgical procedures, such as total joint replacements, to outpatient settings, we reserve high-acuity inpatient beds for the most complex patients who truly need them. The final lever is breaking the exit block. Since a significant portion of discharge delays stem from social care needs, modern solutions like criteria-led discharge and home-first models are essential to ensure beds remain available for incoming patients. Looking forward, the principles established in the past have evolved. Today, our management of surgical beds is powered by real-time data, predictive analytics, and centralized command centers, transforming how we oversee patient flow across the entire system. This section introduces the modern bed management stack. It provides a reference architecture, identifying 4 layers: data, visibility, intelligence, and action, which transform raw hospital data into the right patient in the right bed at the right time. Capacity command centers serve as air traffic control for patients. Drawing on systems like Johns Hopkins Judy Wright Center, these command centers use continuous, real-time data to forecast occupancy and coordinate care across the entire facility. Forecasting is essential for proactive bed management. By using machine learning to predict admission demand, hospitals can shift from reactive crisis management to proactive planning, significantly improving throughput and reducing patient wait times. Technology and culture must be integrated. Relying on software as a silver bullet while ignoring lean culture leads to ignored alerts, while a strong culture without real-time data leaves teams blind. Success requires both. Now we examine how to put these concepts into practice. This section covers building a modern patient flow team, using a maturity model to guide your roadmap, and selecting the metrics that matter for sustained change. A successful patient flow team evolves from a single manager to a multidisciplinary group. Key roles include flow leads, bed coordinators, and discharge planners, all supported by anesthesia leadership to protect surgical recovery bed turnover. Our implementation roadmap outlines 7 steps. We start by naming an executive sponsor and mapping the patient journey. From there, we baseline KPIs, smooth schedules, deploy ERAS pathways, add visibility, and continuously iterate through PDSA cycles. Hospitals typically fall into one of 4 stages of maturity: reactive, coordinated, proactive, or predictive. Assessing where you currently stand allows you to commit to the next logical steps in your capacity management journey. Effective management requires a balanced scorecard. We track metrics across access, flow, stay, and exit. Crucially, we include a 5th column of safety guardrails, ensuring that efficiency never comes at the cost of clinical outcomes. The business case for these changes is clear. Higher quality often costs less. Shorter safe stays, fewer cancellations, and reduced complications generate significant value, helping to justify operational improvements to leadership. Change management pitfalls are predictable. Avoid optimizing silos and isolation, relying on short-term workarounds, or neglecting clinician trust. Sustainable success requires disciplined repetition and maintaining a relentless focus on patient safety. In a well-run system, these levers work in harmony. From overnight forecasting and preoperative preparation to early recovery and discharge by noon, every step is coordinated to ensure a predictable and safe patient experience. Finally, remember to prioritize safety and equity. Ensure that ambulatory pathways remain inclusive and that efficiency gains are balanced by rigid safety guardrails. Ultimately, these processes serve the patient, not just the facility's throughput. In conclusion, flow beats capacity. By smoothing demand, compressing stays, breaking exit blocks, and pairing data with a culture of trust, hospitals can fulfill the goal established in 1999, admitting all planned patients safely. Thank you for watching this overview on surgical bed utilization. For further study, please refer to the provided list of peer-reviewed articles, institutional outcomes, and foundational literature covering operations and quality management.